New Year and happy. No, wait. Let's try this again. Good morning and happy New Year. I need a little more coffee right now. Welcome everybody to the first program of 2017. I have a few entrepreneurial statistical questions to ask for a few more coffee mugs, and then we'll introduce our presenter. I will let you know that. Second part of this team, Frank Shapansky. This is Tom Shapansky. Frank was in a car accident last night, and so he's at home with his leg up per doctor's orders. So he's going to join us via web conference. We figured this all out at about 8 o'clock this morning, so we had to do a little improvisation, so please bear with us. So I have statistics from 2007 and 2016. And the question is, enterprise creation between those 2 years, was it greater or lower? And I'll give you several countries, and what I'll give away the mug for is for the U.S. business creation. Was it greater or lower, and by how much of as a percentage? So, between 2007 and 2016, was the business creation in the United States higher or lower, and what percentage of that was it? Anybody?
Decreased.
It decreased, yes. We'll give you that. So by how much?
10%.
Okay, 10%. We have 10%. Anybody have higher, lower? 15%? 50%. Between the years 2007 and 2016. 30%. So we have 50%, 30%, 10%. Anybody else? Jim?
I'd say 2%.
A 2% difference, lower. Anybody else? Okay. It's actually 14.59% difference, negative difference in business creation in the United States. So Ken, you keep adding to your collection here.
Who doesn't have one? You got a cabinet yet?
I do want to add that we are not as in bad a shape as some other countries. Italy is down 35.77% in business creation. Germany, do you think it's higher or lower? It's down 23.66%. Canada, higher or lower? Higher, 1.97% higher than it was in 2007. France. That's what I thought too, but it's actually up 13.86%. And the top country on the list, the United Kingdom, has had a 31.15% increase in business creation since 2007.
Do you know what some of the underlying factors were?
I just looked at the chart. Pure statistics here. Okay, so my second question is, between 2000 and 2015, do you think our federal percent of government spending on research and development is higher or lower? And if you can give, well, I'll give you the percentage if you can give me the answer. Do you think it's higher or lower? And then percentage increase, or percentage of government spending. That's what it is. Percentage of government spending. So I'll say it's less than 5%, so you don't have to struggle with that. Is it higher or lower? And what's the percent of overall spending? Lori? 2000 and 2015. What's the percentage of overall spending? It's less than 5%. Okay. Anybody else have any suggestions? 2%? 3? Do we have anybody between 2 and 3? Yes, sir. I saw your hand. No? 2.5. Sorry. Anybody else between 2 and 2.5? It's actually we spent 2.41% in 2000, and we're spending 2.17% in 2015. So not too much difference. And if you factor in the fact that we're spending more as a federal, it's actually probably more. You're welcome. So I want to introduce everybody. Frank is still joining us. I see he's still connecting. So if I could pass this around. Actually, I can do this, right?
Keep in mind that the mic doesn't.
You mind introducing yourself? And it doesn't amplify. It's just we stream.
Yeah, my name is Sanyo Park. I joined Bone Pharmaceutical here. Right.
Welcome.
Yeah, my name is Jin Hong. We are currently a resident at the Purdue Technology Center of West Indiana, and then the Obama actually it is not a startup company. It is a startup company. I'm a director of R&D.
Well, welcome to 1 Million Cups.
Hi, Debbie Wargo from WJOB.
Jim Diedlow from WJOB.
Cindy Bertram from the Northwest Indiana Business Development Center.
Ruth Yothman from Planting Possibilities.
Hi, I'm Jeff Conti. I own Coffee Cabin.
I'm Tom Renwald from Auto Frost Corporation.
Welcome.
I'm Jim Rags, a wannabe entrepreneur.
I'm Lori Feld from Small Business Development Center.
I'm Kim Macarill. I'm trying to be a successful entrepreneur.
Ken Gonzalez from the Indiana Small Business Development Center.
Tom Sapansky, IB Diagnostics.
Okay, so just a few more announcements. Next week, Ken and Lori and Jim, are you going to be here next Wednesday as well? Yes. Okay, and Debbie? Yeah. Okay. I will not be here. I'm going to leave a mysterious comment that I'll be in Washington. For what purpose, you might ask? Nothing. I'm not going to bring it up. No. But I will be in Washington. What? No. So we... No, can't discuss. No. Sorry. Thank you, though. I appreciate it. I need a suit for it, actually. I probably should. Actually, I'll just go to Kohl's, buy one off the rack. That always seems to work. Actually, next week, though, Lori's client has been assigned to present, and we hope to get confirmation sometime today. And then also the following week, we have another client from the ISBDC, Jerome Fleming, from Herbal Soak and Soothe, which I just bought a unit for my father for Christmas. And this gentleman is a worker at the mills, decided that he needed something to help with his hands. They were all sore all the time, so he created like a little jacuzzi for his hands. Worked with a company in China to manufacture for them, and he just received 200 units, and he's now shipping and selling these. So it's a very interesting project. So Lori, what's the name of the? Angela Poole. Okay. That's right. Okay. So with that, I want to introduce Frank and Tom Shapansky from IV Diagnostics. Again, we had recorded this earlier, and luckily we had it to load up for the presentation. So, okay.
All set? I'm just going to say thank you for coming out on this cold day. Happy New Year to all. And my brother will be presenting. As mentioned, he was in a car accident. He's okay, just have to keep his leg up. Go ahead, you want me? You're on, Frank.
Okay. Yeah, this is Frank. I'm going to start a video.
Okay. Stop the video. Hang on. Hang on, you gotta stop the video. It started. Okay, go ahead. Can everybody hear this or not? Go. Try to speak a little louder, Frank. I'm in the middle of the room.
Sure. Yeah, this is Frank. Normally I would entertain taking questions during the presentation, but because this was pre-recorded, we're going to let it run to the end, and then I'll take questions and answers afterwards. So with that, I'm going to start the presentation.
Okay, he'll take questions afterwards. And
Good morning. I'm Frank Shapansky. I'm the president and CEO of IV Diagnostics, based here in Crown Point, Indiana, at the Technology Center. I'm here today to tell you a little background on IVD, what we do that's unique and different in the area of diagnostics, specifically for metastatic cancer patients, and the key different where we're going with our next product. So with that, we'll move ahead. The marketplace is really huge. Unfortunately, there's 16 million new cancer patients identified every year globally. Here in the United States, 1.6 million. The market, dollar-wise, for diagnostic tests is over $300 billion globally, growing at approximately 14% a year. Now, what we're about to do is to show you the products that make us unique and different. Take a one step back. This slide illustrates the modalities that are used by physicians today to detect solid tumors, but not microscopic cancer cells. What makes us different is we don't wait for metastatic cancer to form in another part of the body. We identify what we call CTCs, circulating tumor cells, that these imaging systems, such as CAT scans, PET scans, bone scans, cannot find. The difference in size is that a solid tumor, its imaging systems can actually go down to 1 millimeter, which you can see with the naked eye. But a circulating tumor cell can be very small, between 2 and 30 microns in size, which are usually only detectable by a microscope. So what we've done uniquely different is we actually have 2 ways, right, to identify circulating tumor cells. We've created an in vitro test. And if you imagine a vial of blood, it's about 10 ml. It's filled with many different types of cells, red blood cells, white blood cells, leukocytes, cancer cells. The trick is to quickly separate the ones that are not cancerous. So we've designed a way to do this in vitro using the blood sample. And within seconds, you can see that we've separated out the white blood cells, the red blood cells, and what's left is the supernatant, which is circulating tumor cells. With this, we can put the live cells on a slide and actually have a doctor, a pathologist, actually take a look at it, determine that they are cancerous, and they can actually do DNA sequencing on it. Now with this new way, as we're showing you on the screen, is a revolutionary change. We will actually disrupt the market on how you can actually monitor cancer patients, determine the levels of CTCs in their blood. In vivo means inside the body. And if I have a device that can actually look at the cells that are circulating through your bloodstream and do a test for 30 to 40 minutes while you're waiting in the doctor's office, I'll be able to look at 20% of blood in your body and be able to determine precisely the number of circulating tumor cells in your blood. That is a key indicator for metastatic offer it to laboratories and physicians as readily as if they were here in the Midwest. So that's the key ingredient, an nanobiparticle. The overall platform uses 5 sciences: biology, chemistry, physics, systems integration, software engineering. And so what we're doing is we're redesigning it. It's being redesigned so it can be a handheld device. The value proposition, whether we use in vitro or in vitro, is the same. Reason being, the nanobiparticle is the same. But what current tests in the marketplace, like CA-125, which is used for ovarian, CA-2729, which is typically used for breast cancer, they do not emphatically measure any circulating tumor cells. What they do is they look at antigens as an indicator of whether the patient has cancer. So you have 50 to 60% false positives or negatives that can be eliminated with our precise test. Other differentiation is our nanobiparticle is non-toxic. We believe that unless you really need it, why introduce chemicals that are toxic to the body? So, this will give you a snapshot view of what we're designing. It won't look exactly the same, but on the left side of the screen is the prototype illustrating how a probe is attached to the patient's peripheral vein, on the back of their hand and the back of the arm, kept in place, shielded from light, and within that 30 to 40 minutes, we'll get a precise accurate reading of the number of CPCs in that person's body. On the right side of the screen would be a way that's more portable, more mobile. It'll be a wireless. Won't need to be tethered to a computer. It'll still have the ability to capture the data, much like on your phone, be able to then submit it in an encrypted way to the hub in a hospital. If you really think about stretching it out a few years, there isn't any reason why a patient couldn't actually scan themselves once they follow the instructions. But for initial introduction, it will be on a pathologist's office and in a hospital. So if we were to scope out what's the size of the market, if you take a look at the 16 million new cancer patients, right, per year, and you look at an average lifespan of 5 years following their treatment, assuming that they are in fact metastatic and have gone on to either stage 2, 3, or 4, you'll find that what we really have is the survival base of 80 million cancer patients. Our target is 8 million of them. So in a short period of time, say within 3 to 4 years, we can ship 2 million of these devices globally per year and reach a base of about 8 million cancer patients. And if we did it on a different model using a subscription base of $100 per patient per year, you can imagine the revenue that we're going to generate. So this is wearable technology. It won't have to be prescriptions provided by the doctor or the hospital. But we're working out those details now for commercialization. So I want to thank you for attending. It's really been great. And I'll handle any questions you may have now.
Does anybody have any questions? Okay.
From a business perspective, what is the profit that you would have in this product? Or not necessarily the profit, but what's the potential, business economics that you would have as you move forward?
Did you hear that, Frank?
You have to repeat the question.
Okay, as a business, okay.
Yeah, my question is, as a business model, what type of economics are there that
you hope to gain from launching this new product?
Put it real simply, we have a model that provides us with a 90% gross profit margin on our nanoparticle reagent, and we have a minimum of 70% model for any associated product. So that would include apparatus, it would include things like our magnetic separator, it would include things like the device itself. So in thinking about this, having worked in multiple industries in past, including computer software, computer hardware, systems integration, we took a look at this and said there's really the potential for three revenue streams. One being the nanoparticle itself, next being the sale or rental of the device, and then thirdly the way to distribute the nanoparticle to consumers. So I'll explain it in a slightly different way. So if you look at a software model applied to this product, you'd want the ability to download the software into a handheld device for the patient as long as they had a prescription from their doctor. But that could be an annual fee, and then presumably they could renew it. And so they don't get to keep the software. In fact, it's a license. When you take a look at the nanoparticle from a consumer perspective or from a hospital pharmacy perspective, you want to be able to distribute that and do it at a relatively low cost. We currently do $200 per test. So all we have to do is have a way to measure and record the number of scans being done, regardless of where they're being done in the world. Then from the hardware perspective, the device itself would be no different than looking at what does it really cost to make, right, a handheld phone. We always get rebates or discounts, right, from our carriers. They're actually bearing the cost, right, of the entire device. We get a discount on it, and that's because we sign up, right, to either rent the device or sign a contract to use it. So we would use a rental agreement because those units can be returned when they're done. And so no different than when a patient has chemotherapy, generally on a regime for 12 months, sometimes shorter, but average is 12 to 18 months, sometimes longer, sometimes 24 months. It would be conceivable to have a very small rental amount. So instead of paying like $1,000 for the unit, you charge $100 a month. Collectively, that revenue stream gets us to a very big number. So if we were to produce say initial 200,000 units and use them just here locally in the Midwest, and we knew that that revenue stream would bring us at least $1,000, you can see that that would drive a fairly big number, close to 20 million. When you take a look at the real market globally, and there's no reason why we can't, ship from Indiana to other parts of the world, either directly or through distributors, we'd be looking at a first full year production run of about 2 million devices. And that's a real small percentage of that overall market of the 80 million living cancer patients that are out there today. Does that answer your question?
Any other questions?
Yeah, can I just follow up? Do you still need FDA approval? I don't know if I caught that in the presentation.
Yeah, you still need to have FDA approval, whether it's our in vitro test or our in vivo test. In vivo is the device, so it's a different form of approval. In vitro is merely taking a blood sample and running a particular assay protocol for that patient's blood. No device, it's a more lengthy, right, trial involved. So we have to prepare to actually do both. And the reason is, if you take a look at comparison to there's only one FDA standard for this particular test right now. That was originally created by a small company like us in Pennsylvania called Immunicon, which was then bought out by Johnson & Johnson. What we found out that was quite interesting was about 2 weeks ago, a company from Italy actually bought out the entire rights to that cell search Veridex test. And they intend to continue to distribute it and continue to run their manufacturing facility in Pennsylvania. But that just shows you that the global demand, right, is there. So you've got an Italian company now having acquired all those assets, the people over in Pennsylvania, as well as that facility. And so they don't pose us a threat. They're actually potentially a partner for us to distribute the in vivo method because they don't have one. But when in doing a side-by-side test, if we had tried to compare ourselves to the old Johnson & Johnson system, it's like apples and oranges. The reason is they have a totally different mixture of like chemicals, and it's blood only. So we designed the nanoparticle so that it could work either way, either in vitro with the blood samples or in vivo without taking blood. It's the same nanoparticle, just a different formulation. One for blood samples that are taken out of the body, and one where we just merely scan inside the body.
Yeah, Frank, this is Mont. It's very, very difficult to hear everything you're saying, so I'd ask that you try to make shorter responses to the questions, only because we can only hear just a few of the comments that you're making. You mentioned that your product has a 90% margin. Is that the actual test, the sample test that you're talking about, or is that the hardware as well as the actual test sample?
No, we have a model that works really well for the nanoparticle. It's 90%. That means that we can make the product, for 10% of what we're actually selling it for.
Okay.
When you take a look at the hardware's got a lower gross profit margin, but the plan is to actually produce these things with a 70% gross profit margin.
Okay.
Because you get economies of scale when you produce that many.
Frank, follow-up question, please?
Could you repeat, please?
I have a follow-up question. You also mentioned that you can produce 1 million devices in the first year. Was that the hardware, or was that the actual test kits?
It would be both for the first full run. And so our strategy, when you take a look at starting a company up, as you well know, Mont, you have to have not only a sales model, you have to have a strategy of deployment. So our strategy for deployment is to have multiple partners in different continents. And so they may, in fact, sign up for, 20, 200,000, a million. Okay, the demand worldwide is much bigger. And here's the reason why. When you take a look at the cancer statistics worldwide compared to the U.S. has roughly 1.6 million new cancer patients every year. When you take a look at it worldwide, it's 16 million, or 10 times that number. So what that tells you is the demand for the product is bigger outside the United States, which would make us a major exporter. So we would love nothing more than to find the right partners to actually manufacture the product for at least the U.S. demand here in Indiana, and then worry about whether or not we also have to negotiate manufacturing rights to partners that are in different continents.
Okay, Frank, and you mentioned, you know, you can produce 1 million devices in the first year. What's your scale period? When do you see this happening?
Well, it won't be for about a year until we get to that run rate. But I foresee that we could actually make about 200,000 of these once we finish the redesign. So, as you know, we're looking to potentially have an agreement with the Purdue CMEC to make the first batch of the product. And we still have to work out the agreement, of course, but, you know, we're confident that, you know, we can get that done quickly. Build like the first, you know, dozen to 2 dozen of these units and actually use those at test at area hospitals where we're already running our breast cancer pilot study. And so what ends up happening is you've already got data right on the same patients done with blood tests. Now you have an apples-to-apples comparison to run it both ways on the same patients. That proves emphatically, right, that it works better with more volume, more sensitivity, less pain, less needle sticks. So it won't be a problem lining up hospitals to want to do this. It's just a matter of getting out functional units to actually run them.
Frank, my name is Shanur Duvarj. I'd like to know what part of the redesigning are you talking about? Is it Vivo's a part of it, or is it integrated with the mechanics on the iPhone or mobile system?
Okay, I should explain that there's different sciences involved, right? There's about 5 sciences involved, so it's a systems integration effort. So it's more than just electrical mechanical devices. There's also things like making sure that it works, right, with a particular conjugated compound. And by that I mean you have different dyes to consider when you make that product in, say, either a liquid or a powder form. So we have to make sure that we're looking at the physics side of it as well. So we got to make sure that the particular dye we select that's bound with our, you know, nanovital particle works, you know, with precision, so that you can actually go through the skin regardless of skin color, regardless of skin thickness, and so that's the part, that's the testing part, to make sure that you can penetrate and read those circulating tumor cells.
Frank.
They have a static point, right, on a peripheral.
I get that. Just explain to us the liquid part. Is that injectable into the system, or is it externally?
There's three ways to do it. The injection way gets into the circulatory system immediately, and then it has to circulate for about 30 minutes in the body before you begin the scanning process with the optical scanner. The second way is a much preferred way, and that is with a patch. So much like a nicotine patch, you have a bolus release right into the vein. So it's like putting a Band-Aid on the back of the vein, and then there's a quick release as opposed to a slow release. It gets into the vein, and then you have the same amount of time to circulate. The third way is a transbuccal spray, and that's like, say, a breath freshener, and you're spraying the inside of the walls of your mouth because you have many good veins on the inside of your mouth. So there's actually 3 ways. So that's part of what we're doing, and it's not all with one partner. Okay, so we actually have different suppliers, and we always look to have at least 2 for contingency backup.
So the scanning part of it is what? From when the third way, which sounds like the most less intrusive way, would that be? How would you scan it? So you scan the skin or the breast?
You don't scan the breast, okay? let me explain metastatic cancer for a second. So when someone has a solid tumor in their body, right, say in the case of a woman, breast cancer, they remove potentially the lump, they potentially remove some of the sentinel nodes, um, but what ends up happening is there's metastatic growth even after a lumpectomy or a mastectomy, and so those cells are circulating through the body looking for another home.
Right.
They could end up lodging somewhere else, like in the colon, in the ovaries, in the skeleton, in the liver, the lung, the brain. They can move different places. So what we're doing is we're doing two things. We're enumerating, right, how many CTCs are in the body by doing a volume that's at least 100 times more than what you get in a small vial of blood, right? You're able to see, a better sample. When you look at a small, like 10 ml or 20 ml blood sample, cancer cells can be a rare event. Okay, you may find 1, 2, 3, 5, 10 in a small sample. How do you equate that to how much is in the body? It's just a mathematical algorithm. From a simplistic perspective, it's like saying, okay, if I did a 10 ml sample and I have 5,000 ml in my body, I'm going to multiply the number I get for the small sample by 500. That's, close, but it's not accurate. In other words, it's not precise. If I can look at how many are in 10 times that sample and actually look at 1,000 ml of your blood, I've looked at 20% of the blood in your body, right? I should be able to say with more confidence, right, that I know precisely what's happening in your body, and I can take measures as a physician to either change therapy, stop therapy, there's or basically change dosage, right, if I see a rise in the CT6. So what we're doing with the optical way, theoretically, and this is why we have to do the functionality test very soon after we create the new design, is we want to be able to precisely say, yes, we're 20% more accurate because we're getting a count on 100 times more volume. Optically, what I'm doing is I'm just placing the optical scanner on a peripheral point where you have a good vein. It doesn't have to be at the breast. It could be right on the back of your hand or the back of your arm. It could be behind your ear. It could be on your foot. There's many good places to actually track blood flowing through your body. So we prefer it being like strapped to your wrist, for example, and the scanner would be on the back of your hand behind your wrist, and therefore it's going to be more comfortable. It's more humanly economic and ergonomic. So we're designing a device that's not necessarily an iPhone. We're designing a device that will be able to work within every hospital system without worrying about what telecommunication provider you have. Therefore, it's going to be Wi-Fi. Because if you've ever been in a hospital frequently, like I have, you know that sometimes you can't even get out to make a phone call, or you can't see your email or your text messages. You're blocked. So you're better off using Wi-Fi.
So part of it would include a doctor's, a physician's presence. Am I correct assuming this?
Yeah, the actual test could be administered by a attending nurse. The doctor would basically get the encrypted data before even seeing the patient. It would basically be encrypted, sent over to the hub at his hospital or oncology office, outpatient facility. You'd be able to actually compare that to other data, such as tests that he ran via imaging or tests that he ran via, you name it, another cancer assay. Like currently in the market, they run a CA-125 or a 27.29. They can compare it you know, you're using typically a barium solution in the body, and the hospital protocol is that, you know, you might get it every 3, 6 months. Insurance comes into play where you can't afford to have $8,000 to $10,000 scan, you know, every month. Well, with our test, they could actually run it as frequently as every week, and eventually, when this handheld device is in the hands of the patient, and the patient knows how to actually start the scan, it could be no different than a diabetic running their own test to see what their blood sugar levels are. You could run this outside of the hospital, i.e. in the patient's home, and it can be done even daily. So the trick is to do it more frequently, and it goes back to the mechanics and the physics related to the tumor cells. So when they metastasize and move off to another place, and a small, dime-sized, 1 gram in weight tumor cell starts forming in another part of the body, and that little small 1 gram tumor cell can actually be composed of about 10 million circulating tumor cells that have clustered together. And then one day, about 1,000 of them will fit, and they start circulating the body. And if the immune system's not strong enough, or the therapy's the wrong therapy, or if it's not a high enough dosage, those CTCs will double every 48 hours. And by the end of the first week, that patient would have 64,000 of them circulating through the body.
I get that. Frank, I think
Monty's right. The time. I'm sorry, Frank, to interrupt.
Got a question.
I get that. You're getting too much into detail. The part that I'm worried at this stage is your challenge with the hospital lock-in system. And so that's going to be a major issue for you. You know, I understand the parts that you're saying, you know, it's easy for the patient to scan itself, and then that message will be sent to the hospital, coded and all that good stuff. But hospitals will never give out control. I know that for sure. In fact, today hospitals are taking control of doctors, just bringing them all into their system. So you got a huge challenge to face. And from the perspective of especially cancer cells that we're talking about, that's in a million drops. You have multi-millions of those cells. It's huge issues that you're going to be challenged, and I wish you all the luck. It sounds great. I mean, I personally, as a proactive individual, I would say you're doing great work. But it's a huge challenge you're going to be facing against the hospital locking concept that they're following today. Thank you.
There's radical changes going on in the healthcare system, not only, you know, here in the United States, but elsewhere. And I'm not saying that we're focused on trying to get this into the home. What I'm saying is that it could theoretically, right, get there after adoption in the hospitals and oncologist offices, because they are going to want to make sure they get the data while the patient's there. The advantage is that because those circulating tumor cells are doubling every 48 hours, if you have to wait 3 months to get a CAT scan, if you're a stage 2 or stage 3 patient and you're having this problem of metastatic growth and the doctor doesn't even know about it, right? A month or two can go by, and I've seen this with my own family members, where metastatic growth at that rapid rate, when they were just taken off therapy because they were told they were in remission, there's no way of checking, is that really happening in the body till it's too late. And then all of a sudden they're at the next later stage of cancer. And why? Because of metastatic growth. Because there was no frequent monitoring. So what we're suggesting is, yeah, let's have this adopted in the hospital system. We already have hospitals that are partners willing to do the in vitro test. They're more than interested in doing this 2 ways and seeing if it works, because that will actually help the quality of life of those patients. They'll be able to catch things earlier. It has an impact on reducing insurance costs. It's a big time change in the hospitals and oncologist offices. across the hospitals, right, that are currently servicing cancer patients.
Another question?
Yes, how can our community of 1 million cups help you?
Well, there's about three different ways anybody in the room or anybody remotely on the video streaming can actually hear this. And that's basically look at it from the perspective of the patient, look at it from the perspective of the physicians, look at it from a perspective of how do you take our company and get it scaled to that point so it has a huge impact, right? Not only here in the Midwest, but also elsewhere. So when you look at it from a patient perspective, we're currently running, right, a breast cancer study using the in vitro method. We call that test the Velox cancer assay. Okay? So if you know of a patient or even a healthy donor that wants to participate in the study, right, you contact us after this meeting and we put you in touch with the hospital and the research team that's in those sites because they have all of the forms for signing up donors. And it's a small, easily managed thing for a patient. All they're doing is giving an extra sample of blood when they're there first at the beginning before they take their chemo or radiation or combination. That gives us a baseline on the CTCs, and then every 30 days approximately for the next 3 draws. So it's a total of 4 draws for the patient. If you're not interested in being a donor or know someone, you can still evangelize. You can still, talk to people about this. You can talk to doctors. You can get them to say, hey, we know a company, right, that's actually local, right, that's working here in Indiana. Maybe your hospital system could actually become one of the additional sites. But we're trying to build more sites. We're also trying to go outside of Indiana, right, to go after major research hospitals that are either nearby in the Midwest or anywhere in Indiana. And because that gives us even more credibility, because they'll end up basically publishing, right? They'll end up writing papers. They'll end up getting this out into all the medical journals because they're doctors. The other way is if anybody is interested in investing in the company, right? We have 2 ways, one with common stock, one with preferred stock. So we have to have enough money to do all this test, to actually make all these products, to get them out to the market, and also to help identify strategic partners, right, that are not necessarily obvious. Sometimes they're small companies, sometimes they're big. But we are working on that with a number of companies. We're in discussions confidentially with a couple of them so that they could actually be a partner to either roll it out as a distributor or potentially be one of the manufacturing suppliers. So that's how you can help. There's a number of ways.
Thanks.
Okay, Frank, and thank you so much for the presentation. I want to just say to everyone, thank you for listening. I know this wasn't the most ideal presentation because of the, presenter being out remote. But I think there was a lot of information presented. I would say something, Frank, that and it must be difficult not being in the room, but a number of people sort of faded away with too much detail. And I just want to give you a little bit of critique on that because I think you brought up the idea that you're looking for investors, and I think there are potentially some people in the room who could potentially invest, but they weren't really getting the information about the business side of this. They were getting all of the detail about your product and the innovation. And in a presentation where you're trying to find investors, I think the focus should be more on how the investors are going to benefit, how the investment will play out. I don't know if anybody else has anything to add to that at all, but I think there's a lot of thumbs up in the room about that. So. Sure. they're going to ask when people show their hands. Some people don't want to be known as investors in the room. So let me just point out, Frank, this is something I just like to point out. I've learned this lesson myself, raising money, and I just meant respectfully to like critique you on your presentation. I didn't mean, to like get into any kind of conflict or any kind of debate about like the best way to present or anything like that. It was just my observation, so I'll leave it at that. But I want to thank you again for presenting. And if there's any last comments or questions from the room. All right, we want to thank you again, and we look forward to following up with you in the future. And we'll be talking to you here at CMAC as well about your venture. All right, thanks, sir. Thanks, everyone.